This program is brought to you by Stanford University. Please visit us at stanford.edu.
Thanks, Ralph, for that overly generous introduction. I feel like I should offer a rebuttal to give a more balanced view, but instead I think I'll talk about today's topic, which is bacterial pneumonias in the 21st century. Okay, I'm on. All right. So I'm going to start with a case presentation. Last time I was on in the intensive care unit, I was called by a local hospital in the South Bay for transfer of a vacationing British patient who was described as having massive hemoptysis. He'd had a sick child, and he himself became ill about 48 hours prior to admission at Stanford with a flu-like illness. Then he had hemoptysis, as it was described on the way to the hospital, developed shock, and had 2 cardiac arrests in the first 6 hours in this hospital in the South Bay. He was only there 12 hours and was transferred to Stanford. Unfortunately, on arrival at Stanford at about 9 p.m. by helicopter, he was in deep shock, required CPR twice with volume and pressure resuscitation. His initial labs were extremely ominous with a lactate of 30 and a white count of only 300. And his chest x-ray showed a great deal of opacity on the right, some pulmonary edema on the left. Despite nearly continuous resuscitation, broad spectrum antibiotics, multiple pressors, fluids, corticosteroids, mechanical ventilation, he expired 6 hours after transfer to Stanford, leaving behind a disconsolate wife and 2 small children. His blood cultures were positive for 4 out of 4 cultures for group A Streptococcus. So this reminds us that pneumonia, even in healthy individuals, is still a highly mortal disease, particularly when it occurs with a virulent organism and a susceptible host, and in this case, when antibiotics are delayed. And the largest series on group A Streptococcal pneumonia shows that it has about a 40% case mortality for invasive group A, that is positive blood cultures or meningitis, when a patient requires admission to an intensive care unit. So this wasn't atypical, but it was devastating. And if we stand back and think about the epidemiology of inpatient pneumonia today, and I'm going to concentrate today on inpatient pneumonia, there's about 1.3 million admissions per year in the United States. This compares to about 500,000 for asthma or a similar number for chronic bronchitis. So there's a significant burden of disease. The mortality rate currently, by the latest CDC statistics, is about 20 per 100,000 per year. This compares with 11-fold higher mortality in all heart disease or 9-fold higher mortality in malignant disease. But it's still the 6th leading cause of death in the United States. Of course, things have been worse in the past, and we hope that we're not going to have a repeat of this with influenza and pneumonia-related avian flu. But in the great pandemic in 1918, at that time, the Department of Commerce and Bureau of Census were collecting statistics since the CDC hadn't been founded, which was later founded in 1946. And during the great pandemic, there were case rates, and this is an original graph from their paper, that were as high as 320 times the mortality rate that we're seeing currently in the year 2006. So this is happens to be in Philadelphia males, but I could show similar statistics for the Midwest or the South. So this accounted for as many as 60 to 80% of all deaths during the peak of the epidemic. Well, today things are substantially better, and we've come to look at pneumonia as a disorder that's very protean. We group it now, and these are definitions that are agreed upon by the American Thoracic Society and the Infectious Disease Society of America, into 4 groups that reflect the severity of the illness and the likely organisms. Community-acquired pneumonia, as in this case, can be very severe, but is usually less severe, and it's acquired in a community setting. Healthcare-associated pneumonia occurs in patients hospitalized in the last 90 days who resided in a chronic healthcare facility, like a skilled nursing facility, received recent antibiotics or chemotherapy, wound care, or dialysis, so have some reason to be exposed to more virulent or multiply drug-resistant organisms. Hospital-acquired pneumonia occurs within 48 hours of admission and was not incubating at the time of admission. And then a subset of hospital-acquired pneumonia is ventilator-associated pneumonia, which refers to pneumonias that develop 48 to 72 hours after endotracheal intubation. Now, why do we have these groupings as a way of considering pneumonia? They're designed to stratify the illnesses by severity of illness and by likely organisms. And we're forced to do that because we frequently don't know the etiology of organisms when we first see the patient. So if we look in community-acquired pneumonia, inpatient pneumonia, Streptococcus pneumonia, pneumococcus is the most common for inpatient. Viruses account for about 10%. Mycoplasma, H-flu are small contributors. Legionella is about 3%. But 37% of the cases we don't know the cause of. So we can't base our strategies on etiologic agent. We can only base it on setting and risk. The same is true for hospital-acquired pneumonia. Of course, methicillin-sensitive and resistant Staph aureus are common organisms, and gram-negative rods. But still, there's a large fraction, 37%, that we don't know, even despite our best efforts, is what the cause of the pneumonia is. So that's the reason for the groupings. What I would like to do today is to discuss, given this kind of context, the uncertainties in diagnosis of pneumonia, because we're not very good at making the diagnosis and we have trouble with the gold standard. I'm going to talk about newer developments in the treatment of pneumonia and then prevention of hospital-acquired pneumonia. And here I'll concentrate on ventilator-associated pneumonia because it's the best studied. And what I want to do is something a little bit novel, emphasize our local inpatient population, their microbiology, and our methods of what's been called providing quality care, including the use of metrics to examine our own practices and how we do with pneumonia. Well, the first thing I want to do is get something off my chest, which is pulmonologist's principal maxim is that all that is febrile with chest X-ray opacity is not pneumonia. And I know this comes as a shock to many of you. But there is a differential diagnosis, and it includes inflammatory conditions like bronchiolitis obliterans, organizing pneumonia, chronic eosinophilic pneumonia, hypersensitivity pneumonitis, vasculitides like Wegener's or diffuse alveolar hemorrhage, or malignant conditions like airway obstruction with secretions that are obstructed in the distal airways, bronchoalveolar cell carcinoma, or even postoperative atelectasis or contusion. So the first thing that we have is a number of confounding disorders that we frequently are not very good at making the diagnosis of. So here's a young woman with fever and airspace opacity. Looks pretty good for bilateral basilar opacities. It could be multilobar pneumonia, but actually it is bronchiolitis obliterans, organizing pneumonia, and inflammatory conditions treated with steroids rather than antibiotics. And here's a person with a left lower lobe, classic opacity, and this, unfortunately, is bronchoalveolar cell carcinoma. So these are the kinds of confounding problems that we have in trying to make the diagnosis. So how do we make the diagnosis? And I'm going to now start referring to the American Thoracic Society and the Infectious Disease Society of America guidelines, since these have become the standard of care. What they say is the appropriate, quote, appropriate clinical history, exam, imaging, and then the question is, what additional tests might be useful? And I want to quote from their paper published in Clinical Infectious Disease this year, which provides these guidelines. The recommendations for diagnostic testing remain controversial. The overall low yield and infrequent positive impact on clinical care argues against the routine use of common tests like blood and sputum cultures. But then they waffle. Conversely, these cultures may have a major impact on the care of an individual patient and are important for epidemiologic reasons. But somewhat more usefully, they do provide us with a table with indications for doing additional diagnostic testing and some additional diagnostic testing that might be offered to patients to secure the diagnosis. And without trying to memorize the table, I think it's fair to say that in more severe illnesses that are inpatient, blood cultures and sputum cultures are generally indicated. Pneumococcal urinary antigen testing is more and more valuable, and it has relative sensitivity. Legionella urinary antigen testing for just the serotype 1, which is about 70 to 80% of Legionellas, is also a valuable test. So I think in general for inpatients, we would probably get blood cultures and sputum cultures in everybody, and antigen testing is useful. Now, unfortunately, the problem of diagnostic criteria becomes much larger in immunosuppressed or chronically ill populations because they may be colonized with organisms, and they have coexisting diseases that are easily confused with pneumonia. And then they have unusual organisms that sometimes result in atypical radiographs. So here the problem becomes more difficult than in the outpatient community-acquired pneumonia. And the paradigm and best studied group is patients in intensive care units being mechanically ventilated with endotracheal tubes in place because literally they develop pneumonia before our eyes. And we can investigate why they develop it, what the source of it is, how to treat it, how it unfolds, and what the resolution of it is. Unfortunately, for all pneumonias, the only gold standard diagnostically is histology, and that's not readily available in most of our patients. So this presents the challenge and tees up the methods that have been used to try and make these diagnoses. So if we go in the intensive care unit, this is the problem we always have. Here's a preoperative normal chest radiograph, postoperative after cardiac surgery. So there's left lower lobe is opacified now. You can't see the hemidiaphragm or the aorta. There's some little air bronchograms. And the question is, does this person have pneumonia? And the answer is, we have no idea. Air bronchograms in ICUs about 60% of the time correlate with histology of pneumonia. This could easily just be volume resuscitation, left lower lobe atelectasis, and an opacified left lower lobe. So that's the problem. So what have we done historically? We use clinical diagnostic methods, clinical signs and symptoms, and the most common standard has been a new or progressive radiographic opacity and two of the following three: fever more than 38 degrees, leukopenia or leukocytosis, and purulent secretions. Now, if you compare this to my gold standard, that is histology, as was done in Barcelona, only about, if you use these measures to decide whether someone has ventilator-associated pneumonia, sensitivity is about 69%, the specificity is about 75%. So not a great method, but the one that we've traditionally relied upon. So in the last, let's say, 15 years, there's been a lot of enthusiasm for doing something more specific and quantitative, and that has been doing quantitative cultures of lower respiratory tract secretions. And this would be obtained bronchoscopically, so patient develops new opacity, fever, white count, purulent secretions, and a bronchoscope's inserted in their airways, goes down to the area of interest on the radiograph and does a lavage, squirts 140 cc's of saline or more into that area, suctions it back, and then does a quantitative culture. Or you can push a brush out, a protected brush specimen, and then a threshold of colony-forming units per milliliter is established to try and establish whether or not the patient has pneumonia. Of course, this requires a bronchoscopist to obtain the specimen, preferably, very much preferably before antibiotics, and it's awkward and occurs at all times of day and night. The question is, does it help? Well, so now we have to go back, fortunately, to histology and more definitive methods to assay the method. So here we have a study done in 25 mechanically ventilated patients who died within an ICU, and just prior to death, they had a bronchoalveolar lavage, a protected specimen brush, and just routine suctioning out of their endotracheal tube to try and figure out, do they have pneumonia? They met other clinical criteria for pneumonia. And then compared with immediate post-mortem bilateral histology and culture of lung tissue, the diagnostic methods had a sensitivity that was quite variable, like 40 to 80%, and a specificity of about 70 to 90%. Now, in general, when you aspirate secretions from an endotracheal tube or from an airway, you have more organisms in the upper airways than in the lower airways, and less specificity for true etiologic agents of pneumonia. But all techniques miss 17 to 83% of the organisms, despite attempts at quantitative methods. So all techniques are of limited value. So one of the problems is establishing a threshold. What we're really trying to do here is something like is done in quantitative urinary cultures, where we establish whether someone has a UTI by the colony-forming units per ml. But unfortunately, it doesn't work quite as well in the lung. And you have to establish a threshold. So typically the threshold has been 1 million colony-forming units from endotracheal tube aspirates, but the sensitivity has been very variable across studies. And it's been 10 to the 4th or 10 to the 5th organisms per cc for bronchoalveolar lavage. And obviously, which one you pick affects the sensitivity and specificity. And it's been about 1,000 organisms for protected specimen brush attempts. Well, since there's been enthusiasm for this, since there are many proponents of this method, the question is, does it make a difference to adopt quantitative methods? And this could be used not only in the ICU and ventilator-associated pneumonia, but in other analyses of community-acquired pneumonias that did not require intubation. But in this study, there were 780 immunocompetent, mechanically ventilated patients who had suspected ventilator-associated pneumonia. They were enrolled in 28 ICUs in Canada and the United States. And then they were randomly assigned to either quantitative culture via bronchoalveolar lavage or non-quantitative culture via just an endotracheal aspirate. Essentially, they were treated with broad-spectrum empiric antibiotics until the cultures became available, and then they received targeted therapy if possible, or if the cultures were negative, in some cases it was stopped. This is much more common in the quantitative culture arm. But of course, the physicians retained the right to continue antibiotics if the patient was unstable, and the outcome was no difference in 28-day mortality, maximum organ dysfunction scores, or overall use of antibiotics in the New England Journal last year. So this doesn't give us great confidence that the outcome is going to be different adopting expensive quantitative measures to try and make the diagnosis of pneumonia in our sickest patients. Well, maybe a more attractive measure, since quantitative cultures or clinical imaging or signs and symptoms aren't very sensitive and specific, maybe a more attractive measure is making the diagnosis by the host response. Since many people carry organisms that are potentially pathogenic but don't develop disease. So here's a list of candidate biomarkers that there's some literature on. C-reactive protein, like our cardiology friends. Fibrin in smears from sputum, showing that there's been some lung injury. Procalcitonin, of course, a pro-hormone that's elevated in inflammatory states. TNF-alpha, interleukin-1 beta, or a new biomarker that's received a lot of attention, which is a triggered receptor expressed on myeloid cells. It's a cell surface molecule that is upregulated by microbial products and is felt to be somewhat more specific. So the question is, can we look at the biologic response and figure out whether the opacity is really pneumonia? So again, in the New England Journal a couple of years ago, there was a sentinel study on this. The study examined 148 mechanically ventilated patients with pneumonia and the various biomarkers I just outlined. And they examined CRP, procalcitonin, TNF, IL-1, and this new triggered receptor expressed on myeloid cells. And they found that to be the strongest independent predictor of pneumonia, much more than any of our prior clinical signs or imaging that we've conventionally used. And if you just look at the graphs from that article, you can see both in community-acquired pneumonia, ventilator-associated pneumonia, the measure tended to be elevated, although there were some positives in the no pneumonia group. And if you look at a receiver operating curve, the sensitivity and specificity of this cell surface molecule is pretty good. So I would say that this is proof in principle that we might be able to look at the host rather than look at the organisms to figure out who's infected. And I would conclude the most promising method for the future is probably biomarkers combined with clinical data, establish a high prior probability before the test, and then apply or look at biomarkers. Of course, many subsequent studies have indicated that this particular biomarker is elevated in other inflammatory conditions like gastric peptic ulcer disease and other kinds of things, but in general, it does appear to be more commonly elevated in pulmonary disorders, and it's somewhat promising. The current guidelines that date from 2005 from the American Thoracic Society and the Infectious Disease Society of America still favor invasive diagnostic testing with quantitative lower respiratory tract cultures, but they do concede that it may have no difference in clinical outcomes. And for that reason, most ICUs in the United States have not adopted this, and neither and it hasn't been broadly adopted for community-acquired pneumonias that are severe either. But there is still enthusiasm for it, and the official recommendations still favor it. Now I'm going to change my page and talk about the treatment of pneumonia. This has become a lot more complex than most of us are used to. So there are also American Thoracic Society, Infectious Disease Society of America guidelines. I regard them as complex. I'll show them to you in a moment. And essentially, they designate the therapy for community-acquired pneumonia by the appropriate site of care. So whether it's an outpatient, inpatient, or ICU patient, and hence by severity. And then for healthcare-associated pneumonia, they designate the care by likely resistance, excuse me, likely resistance profiles of organisms, dividing it into low-risk and high-risk groups based on whether there's a likelihood of a multiply drug-resistant organism. So if we look at the guidelines, for example, in community-acquired pneumonia, if the patient's an outpatient, it has implications for what the likely organisms are, and the recommendations are different for that group than for inpatients or ICU patients. And for the healthcare-associated pneumonia group, there are high-risk and low-risk groups, and these need to be stratified. I doubt that anyone in the audience, if I took this slide off and I tested you all, would immediately replicate this slide, except possibly Jose Montaya or Brian Blackburn. So what's the solution? The solution is that the infectious disease group, the quality group, the ICU group has all collaborated to try and codify the ATS, Infectious Disease Society of America guidelines and order sheets to standardize the care. So you should start looking for these on the wards. They're going to be there for community-acquired pneumonia and for hospital-acquired pneumonia, and it's, I think, the only reliable method. Now, there are some intriguing new ideas in the treatment of pneumonia, and I want to share those with you briefly. So quantitative methods of the types I've been referring to have taught us that the colony-forming units per milliliter reduces rapidly with antibiotic therapy of pneumonia. Antibiotics are rapidly effective in killing the organisms. Of course, there still remain major concerns with our therapy about the emergence of multiply drug-resistant organisms with repeated or protracted antibiotics. And these two things have stimulated interest in maybe we can get away with less antibiotics, create less multiply drug organisms, and be just as effective. Because there's really no sound evidence that 7 to 10 days of antibiotics are required for adequate treatment of mild to moderate community-acquired pneumonia. And there's also a couple of very large trials in ventilator-associated pneumonia that also indicate that, at least in some select populations, the conventional 14 to 21 days of therapy is too long and is unnecessary. So I'm going to show you one of these trials, published in the British Medical Journal last year. It's 186 patients who were hospitalized in 9 secondary and tertiary care hospitals in the Netherlands. And in Britain, the recommended therapy for community-acquired pneumonia is amoxicillin, given IV for moderate or severe cases. And so these patients received 3 days of IV amoxicillin. If they showed some improvement, it was either stopped after 3 days or 5 more days was given. 38 of the 186 patients didn't improve within the first 3 days, and so were excluded from the trial. So it's important to point out this is a subset of these patients, although it's a large subset. Clinical success for this trial was 93% for both groups. And the radiologic success was 86% in the short course, 3 days, and 83% in the long course. And adverse events were more common in the 8 days of amoxicillin than 3 days of amoxicillin. And as I say, there are 2 other large trials in ventilator-associated pneumonia that show that 5 or 8 days of antibiotics are frequently, usually, equally effective to more protracted care. So this shows the short-course chemotherapy, and this is a cumulative event-free outcome. It was at least as good as the 8 days, the 3 days versus the 8 days. And if you look at a community-acquired pneumonia score, where better is higher, the short course group had slightly worse scores in the beginning at day 0. By day 3, they were very substantially overlapping. There was no difference in the outcome between 3 and 8 days for those patients. So this is intriguing. Now I'm going to again change my page and talk about prevention. I'm fine. So prevention of inpatient pneumonia. Hospital-acquired pneumonia occurs at a rate of about 5 to 10 cases per 1,000 hospital admissions. Most of it's in the ICU. It's 6 to 24 more common in mechanically ventilated patients, as I've already indicated. And it accounts for about 25% of all ICU infections and 50% of all antibiotic usage there. And it has a huge burden of expense. It increases the average stay for patients if they get hospital-acquired pneumonia by 7 to 9 days. If I translate those to Stanford dollars, it's $30,000 a day in the ICU. So we're talking $200,000 to $300,000 if somebody gets ventilator-associated pneumonia. And it has an attributable mortality of 20 to 50%. So this is a big deal. If we look at the organisms that cause in our own ICUs ventilator-associated pneumonia, about 40% of them are actually Staph aureus. 28% sensitive Staph aureus, another 12% methicillin-resistant Staph aureus, and the entire balance are gram-negative rods. Some of these multiply drug-resistant, potentially like Pseudomonas, Serratia, or Stenotrophomonas. So this is the population we're dealing with. How do people acquire ventilator-associated pneumonia? This pneumonia that occurs before our eyes and has so much mortality and acts as maybe as a useful model about pneumonia diagnosis and treatment. They acquire it in the usual way pneumonias are acquired, by aspiration of infected secretions. In this case, it's subglottic secretions above the cuff of the endotracheal tubes. The tubes in their trachea, above the cuff, secretions accumulate, and they aspirate them into their lung and develop pneumonia. There's an average of about 3 to 4 Cs above the endotracheal cuff in intubated patients. And these secretions above the cuff really come from colonized oral secretions or from reflux gastric secretions that are colonized. So there's considerable evidence that a simple strategy like sitting the patient up diminishes the frequency of reflux into that space above the cuff and then aspiration causing pneumonia. And we know that labeled gastric secretions are tenfold more likely to be aspirated into airways in just completely supine, flat patients in intensive care units compared with semi-recumbent patients. And if you culture the organisms from the stomach in these patients and then culture the airways, 68% of the time in supine patients you get the same organism. But if you sit the patient up, only 32% of the time you get the same organisms. And there's some small randomized trials that show that ventilator-associated pneumonia is more common in prone patients that are lying flat than in patients sitting up. Again, small numbers. 11 out of 47 prone patients develop ventilator-associated pneumonia, 2 out of 39 sitting up. Nonetheless, this has become a standard, even though the data is scanty, it has become a standard because it makes biologic sense of sitting the patient up in all intensive care units. Now, another thing you might be able to do to prevent pneumonia in this group is something mechanical. So here's an endotracheal tube in a patient. Here are the incriminated secretions. And there are endotracheal tubes commercially available that have an extra port that can just suction above the cuff and try and remove that source of infection. And these are called high-low trachs, and we now place them in our intensive care units of patients that are at very high risk of developing ventilator-associated pneumonia. And this actually works. In a meta-analysis of about 900 patients in 5 randomized controlled trials that were culled from 110 studies reviewed, this subglottic drainage reduced the incidence of ventilator pneumonia by nearly half. And it also delayed the onset of it, indicating that patients that required only transient intubation probably be less likely to get the pneumonia. Now, another thing you can think about to do to try and prevent pneumonia in the hospital setting is not allow so many flora to develop, colonized flora in the oropharynx that seed the lung. And one way to do this is oral decontamination. This is a slightly more controversial area, but I think it's one that is sort of coming into its own. So general enteric decontamination using non-absorbable antibiotics has fallen out of favor in the United States because of fear of developing multiply drug-resistant organisms. But topical antisepsis does not carry that same fear, and we're not necessarily talking about antibiotics. We're talking about antiseptics like hydrogen peroxide or iodine povidone or chlorhexidine. This oral decontamination has been submitted to randomized controlled trials. I think the most impressive ones, the American Journal of Respiratory and Critical Care Medicine. And this just shows the cumulative risk of developing ventilator-associated pneumonia when on a ventilator if you receive no oral decontamination versus receive it with chlorhexidine or chlorhexidine and colistin. And overall, it reduced ventilator-associated pneumonia by about 35%. And there is a meta-analysis now published just in the last month in Critical Care Medicine that looked at this across 7 adequately randomized controlled trials, and it had an overall effect of about 30% in reducing pneumonia. So all of these are, I think, methods of looking at the environment of care for our patients in the hospital and trying to figure out if we can make their stay safer, make their stay less likely to be complicated by nosocomial infections. So what have we done at Stanford about this? We've implemented all of these things. We initiated efforts about 10 years ago to keep the head of the bed up, and the first evidence occurred. But I have to say that we didn't have consistent results until we started auditing it weekly, which in a fit of pique, I finally did in March of 2007, and now we have essentially 100% compliance with people having their head up. We also introduced oral decontamination in 2005 with hydrogen peroxide. Now we've moved to chlorhexidine, and we began inserting double lumen tubes for subglottic suctioning in 2006. And it's gratifying that our ventilator-associated pneumonia rates have declined. The blue lines are the National Nosocomial Infection Surveillance Project of the CDC that estimates what the average incidence of ventilator-associated pneumonia in patients in the United States is among a very large group of participating hospitals. And they run about 6 per 1,000 ventilator days, which is exactly where we were before we instituted measures to try and improve the environment of care. And last year, we essentially halved our ventilator-associated pneumonia rate. Now, the last thing I want to talk about, because I know that Ralph wants to get to questions, is preventing the spread of resistant organisms, another feature of patient safety and also that plays into the morbidity and mortality in nosocomial infections. So because 40% of our infections are due to staph, and because methicillin-resistant Staph aureus is becoming more and more epidemic throughout the United States, I'm going to use that as a marker of the discussion of how to prevent nosocomial spread of infections and where we're at there. So methicillin-resistant Staph aureus is dependent, of course, on the MEC gene, part of this Staphylococcal cassette chromosome that encodes pin-binding protein 2A that confers resistance. And there's generally 2 types. Well, there's actually 5 types, but healthcare-associated MRSA, types 1 through 3, is more commonly multiply drug-resistant, not just methicillin-resistant. Community-acquired organisms tend to be methicillin-resistant, but not multiply drug-resistant, although there's a lot of overlap. But this is a big problem, spread of this in hospitals. Approximately 20 to 30% of newly colonized patients develop infection within 1 year. And among colonized hospitalized patients, those in ICUs have, in the biggest study, about a 27-fold risk of developing infection. So it's not just colonization, it's also infection, and it's a serious problem. So the standard measures to control methicillin-resistant Staph aureus in our ICUs, our hospital, are hand hygiene, contact precautions. Surveillance cultures are controversial, and they're probably required largely in areas where there's a lot of nosocomial spread. Environmental measures, and then the house staff, I think, frequently wants to eradicate carriage, but that's extremely difficult, and it's very unconvincing that antibiotic therapy is useful for that. How do we do? So here is a really interesting graph provided to me by the quality department. This is hand hygiene, the secret shopper that goes into any ward and sees whether nurses or physicians, when they go into a room, wash their hands or use gel going in and coming out, or don't. The blue bars are in May, when the Joint Commission was here. And there was tons of publicity. And what do you know? Everybody does hand hygiene. And then in June, it falls to this level. So this is the opportunity for all hospitals, including Stanford, to do better on their control of nosocomial organisms that cause pneumonias. We monitor this as well in our ICUs. This is MRSA positive cultures in the last 6 months. The bars that have stripes in them are people that brought this in from the community, and the solid bars are the first positive cultures that occur in the hospital. Now, when we have a little peak in the number, that is, whenever it gets to be more common than it was last year in that month, we do a contact investigation, kind of epidemiologic piece where gel electrophoresis is used to type it and see if it seems to be nosocomially spread. And I'm embarrassed to say that in June there was one that was nosocomially spread. So this remains a continuing challenge. So I'd like to conclude so we have time for questions. And these are my conclusions. The diagnosis of pneumonia remains challenging, particularly among inpatients with confounding disorders, and we don't have a gold standard. The treatment has become more complex and is now stratified by severity and risk for multiply resistant organisms, since the etiologic agent is frequently unknown. And prevention in hospital settings is becoming more robust, more informed by clinical data, and improved by efforts at quality improvement. I started the talk saying I was going to talk about old habits and new approaches. So the old habits were to make the diagnosis of pneumonia strictly on clinical grounds. Now I'd say that still is the most common method, but on the horizon are quantitative cultures, more specific tests like urinary antigens and some of the more common etiologic agents, and biomarkers to try and decide who really does have pneumonia. The treatment has always been based on the fund of knowledge of individuals, picking an antibiotic that seemed appropriate for the setting, but it hasn't been codified in the way, let's say, tuberculosis therapy was always codified by the CDC, and there were always official recommendations. We need to get used to the fact that that's what's happening in pneumonia generally now. Codified recommendations that everyone signs off on, and you're going to have to look them up just like you used to look up TB recommendations. So it's treatment by protocol, stratified by severity and MDR, multiply drug-resistant risk, and I believe that shorter course antibiotics will gradually come into vogue and be a useful mechanism for preventing multiply drug-resistant organisms. And then we used to do prevention largely by vaccine, like the Pneumovax, which of course is only useful for invasive pneumococcus largely, that is bloodstream infections and meningitis, and isn't all that effective at all for pneumonias. Now we do prevention by vaccination and attention to the environment, sources of infection, and we try to think of new proactive measures to improve the environment of care. So I'll stop there. Jose, you want to have a run at it? And I have my own opinions, but go ahead. This patient incidentally had a spleen, and the spleen at autopsy was consistent with a reactive spleen to the group A strep.
I think that is the bigger point that the patient should be placed in the host, obviously, makes the major point that I think not appropriately mentioned that these patients by far, the recommendations are for immunocompetent protocols. But in the immunocompromised setting, then the number of applicants widens, which are differential, and specifically the skin issue, pneumococcus become the largest threat. However, not to forget that they also are at risk for Legionella viruses, and there are about 4 or 5 pathogens that can take a patient home to the ICU within 48 hours. And there are not many, like Legionella, pneumococcus, viruses, group A strep, PCP. But keeping all that in mind, in a splenectomized patient, pneumococcus is the biggest threat. And ceftriaxone maxiphaloxacin should be the reflex on these patients. So what we have done is, as soon as we get the phone call and we get the history right out, the lack of screen, we immediately make a point of get the blood for sure, use ceftriaxone and maxiphaloxacin.
Dr. Gibbons? Dr. Rizk, do you want to comment on
Well, I'll just make one comment on that. So if you look at the most current antibiogram at Stanford Hospital, there's about a 7% resistance to pneumococcus in the isolates that we have. That means that they're resistant to more than 2 micrograms per milliliter of penicillin. And for the quinolones like moxifloxacin, levofloxacin, it's quite encouraging that there's a less than 1% resistance in the United States. But if you look generally, as Jose is saying, if you move from outpatient community-acquired pneumonia to inpatient to ICU or towards immunocompromised patients, the spectrum changes from mycoplasma and chlamydia and streptococcus. It goes, starts with those 3 organisms. Mycoplasma and chlamydia become much less common. Streptococcus becomes much larger, and hence the urgency for splenectomized patients. I'm sorry, go ahead.
Dr. Rizk, you spoke very eloquently about the treatment of pneumonia by healthcare setting. And in our inpatients, we've kind of recognized recently the importance of the timing of antibiotics. What systems do we need to employ to ensure that patients get treated in adequate time?
So the question is, there's been a recognition that rapid treatment of patients is probably important, and what system should be employed to make that happen in the healthcare setting. So let's just back up a little bit and say the evidence that rapid treatment of pneumonia improves prognosis is essentially in the over 65 group. There are 2 very large trials that were retrospective using databases from CMS, the Medicare Intermediate. Each study had about 14,000 patients, and it just looked at what the overall survival was depending on the duration of time from the patient seeing a doctor to the antibiotics being given. That evidence is quite strong. However, there's concern in some circles, and some professional societies have pushed back about it, that it may lead to overtreatment of people because of trying to meet that deadline. The previous Infectious Disease Society of America guideline was 8 hours. Now the CMS intermediary has insisted that it be 4 hours, and some of the payers have jumped on board and said that we're going to pay you less unless it happens within 4 hours. My own view is that the balance of information still favors that rapid treatment improves prognosis, but it has not been proved very well in the under 65 age group. Now come to your question. So I think that protocolized treatment and having a protocol for how patients with possible pneumonia are treated when they first enter an emergency department or a clinic is the best way to make it happen rapidly. And I think that it's a point well taken from IDSA and the ATS and the people that are concerned about the 4-hour limit, that doesn't mean that if the diagnosis is uncertain that you should treat them with broad spectrum antibiotics just to make sure you get under the 4-hour mark. If it has to go over 4 hours because there's so much uncertainty or extenuating confounding disorders, I think that's probably tolerable in most patients.
Former resident, Dr. Daniels.
One question for you. 2 questions. First is, in a study that limited antibiotics in the patients that got a longer course, you said that I think there was 21% incidence of complications. Those complications primarily C. diff, or were there other complications in addition? And then the second question is do you see a role for DNA microarray technology, both to analyze microorganisms as well as looking at post-inflammatory factors in a rapid fashion?
Well, let's see, the question, I'll do the second question first, microarrays. So of course we all believe that microarrays and host response is the golden solution to most disorders. And in principle, I would agree with that, although I haven't seen yet any practical application of it in the diagnosis of pneumonia. I thought you were going to ask about PCR in pneumonia, and that's another area where there's a lack of standardization, but it seems promising, but probably overly sensitive, and the problem of colonization and true infection is a very large problem there. I'm sorry, the first question? Oh, right. Okay, so the longer course limb of that study in the BMJ, their problems were not a little bit of C. difficile, but that wasn't prominent. Allergic reactions to it, nausea and vomiting, just failure to tolerate the drug. Not serious complications like, empyemas or other things that you wouldn't anticipate.
I'm interested in the myeloid biomarker and regard it as a threat to the well-established white I guess I need to know something more about its action and its timing. If it no more than parallels the white count, of course, that's cheaper, I imagine. On the other hand, I don't know the rate at which cells come out of the compartment in the marrow, go through the blood, go out to the tissues. Your first patient was very interesting, had 300 white count.
Right.
And I've never understood whether the rate of release travels through the blood and deceives us with regard to the height of the white count.
Right.
I wonder in particular for that kind of person, whether the biomarkers they look at.
No.
Please try and summarize that comment.
Well, the question is, it's intriguing that this cell surface molecule that responds to microbial products that is expressed on myeloid cells has been used as a biomarker. And how does that correlate with the white cell count, the conventional biomarker? And the answer is, in that New England Journal study, it correlates much better with the presence of pneumonia. But it is not specific for pneumonia in the same way that procalcitonin is not specific for pneumonia. Procalcitonin is expressed in almost anybody that has a severe inflammatory response. And interestingly, procalcitonin is normally made by C cells in the thyroid, but even in patients with thyroidectomies, they have high procalcitonin levels when they're sick. But I think this is more a proof of the principle. I'm not sure that this biomarker itself will be the gold standard. I think it's a response to the fact that our old clinical measures don't have very high sensitivity or specificity, and they're frequently elevated in conditions that might be confused with pneumonia. So it's the search for a blood test. It's the troponin of pneumonia.
Dr. Pinto?
You've talked a little bit about non-antibiotic adjuncts that can help outcome in ICU patients. What are the non-antibiotic related interventions that we can do to non-ICU patients? Like you talked about the head of bed. What's the role of pulmonary toilet? I mean, how effective are those things in keeping people out of the unit and improving overall outcome?
So the question is, are there other adjunctive measures that are useful for the prevention of pneumonia outside of the ICU? And I think the only one that is demonstrated, and it's not really for pneumonia, is the pneumococcal vaccine, Pneumovax. I'm not aware of any studies that have looked at the role of respiratory therapy, for example, in preventing outpatient pneumonias in patients that have, respiratory difficulties. There's a lot of literature around the role of respiratory therapy in cystic fibrosis in patients with bronchiectasis, and there I think it has a role. For the otherwise healthy person or the person that chronically aspirates because of neurologic deficits, I'm not aware of any other useful adjunctive measures, but it's not a field that people have spent a lot of time on, and maybe it will be. Well, I know that there is one study that has cultured neckties and shown that they are a frequent carrier of nosocomial organisms. I don't know of outcome studies of not wearing neckties, although I'd be glad to be in the effector limb of it, of a randomized trial.
Norm, you and I have discussed the issue of treatment by protocol and how to encourage people to think about mass customization in the sense of you do the right thing 80% of the time, but also know that 20% when you should deviate. How do we need to change medical education to cultivate that new skill set?
The question is, how should we educate differently our trainees to cultivate the habit and practice of using standardized protocols that are best practices to optimize care? And I guess it starts really in the medical school and with a group ethos of agreeing that many recommendations that societies and expert opinion or consensus panels have created are really not widely adopted because we don't have the methodologies of everyone thinking reflexly that they need to look it up. And that's why I instance the CDC ATS guidelines for tuberculosis. Because it's a reportable disease, because there was an apparatus around it, everyone learned that we treat tuberculosis patients in a standard fashion because they're contagious. It used to be the leading cause of death before 1945, and that protocolized care works. We need somehow to export that to all the other complex areas where the information base is exploding and even experts have trouble remembering the recommendations. So I think it's going to probably have to start in medical school. And all of us, of course, have to model it with our trainees. And that's probably a very big point as well.
The preceding program is copyrighted by Stanford University. Please visit us at stanford.edu.